right, so I'll be presenting a case of refractory hypertension and hypokalemia in the setting of licorice consumption. So this is a case report. In this case, kind of is about looking at causes of secondary hypertension, which affects 5 to 10% of the hypertensive population, with hyperaldosteronism being the most common cause. And just reviewing the pathophysiology of hyperaldosteronism, the excess aldosterone leads to sodium reabsorption, potassium excretion, and this results in the clinical picture of hypertension, hypokalemia, and suppressed renin if this is primary hyperaldosteronism. So our case was a 46-year-old male with a history of hypertension who presented to his primary care doctor with dizziness and worsening hypertension based on home blood pressure readings. His blood pressure had been previously well controlled with lisinopril 10 milligrams daily. So going to the center in our at our initial visit for this complaint, his vitals were notable for hypertension, blood pressure of 191/97, and he was bradycardic as well with a heart rate of 40. We got labs. The serum potassium was low at 2.6, and an EKG was checked, which was notable for sinus bradycardia and a borderline prolonged QTC. So interventions from this visit, they added amlodipine 10 milligrams and placed the patient on potassium supplementation with potassium chloride 40 milliequivalents daily. The patient was brought back 1 week later for a lab check. That visit, potassium was persistently low at 2.9. He also remained hypertensive, although we do not have the recorded reading in the chart. So at that visit, lisinopril was increased to 40 milligrams daily, and the potassium supplementation was increased to 40 milliequivalents twice daily. And due to persistent hypertension with an unclear etiology, the further workup was obtained. Of note, the serum creatinine had been normal throughout all these lab checks, but further workup included renal ultrasound, echo, stress test, which were all normal, and then a urine microalbumin creatinine ratio, which was normal. And the patient was referred to nephrology for further evaluation. At the nephrology visit, which took place about a week later, blood pressure was 167/93, so remained elevated. Serum potassium was improved at 3.3, but still low. And then aldosterone and renin levels were checked, which was notable for a suppressed aldosterone and normal renin levels. And so at that visit, the differential included the syndrome of apparent mineralocorticoid excess, which is otherwise known as SAME. Patient was brought back to the PCP 1 week later. Blood pressure was 146/92, which showed some improvement on the current regimen. And at that visit, the patient interestingly reported that he had been eating 6 ounces of candied licorice every day, like religiously, for the past several weeks. And the reason he brought it up is because he had read or saw online that licorice can contribute to hypertension. So he thought it was important for us to know. So at that visit, instructed the patient to stop licorice and potassium. And we brought him back for follow-up, which I'll talk about in a second. So our working diagnosis is the syndrome of apparent mineralocorticoid excess. And just thinking about the pathophysiology and how licorice contributes to this, there's a component found in licorice called glycyrrhizin, and this inhibits cortisol deactivation in the kidneys, which causes an excess buildup of cortisol and leads to stimulation of the renal mineralocorticoid receptors. And so this leads to the clinical findings of hypertension, hypokalemia, and notably a suppressed aldosterone level, whereas in hyperaldosteronism, we see an elevated aldosterone. So thinking about follow-up for this patient, 1 week later, we had brought the patient back. His hypokalemia had resolved off of supplementation. And at subsequent visits, his antihypertensive agents were able to be de-escalated. So this case served as a really important reminder for all the providers involved in this patient's care to review dietary practices as part of the clinical history, and specifically thinking about licorice consumption when we are seeing cases of refractory hypertension. Learning points for the case, to recognize the clinical signs of hyperaldosteronism, interpret plasma renin activity and aldosterone levels, and then to recognize this syndrome of apparent mineralocorticoid excess, which is associated with severe hypertension, hypokalemia, and then suppressed aldosterone. I'll be happy to answer any questions.
All right, great. Thank you so much, Laura. So are there any other known drivers of this hypertension kind of along the same pathway? I see you have kind of licorice at the top and then your pathway and then kind of hypertension at the bottom. Is there any drivers in consideration?
Beyond the licorice, or
Yeah, beyond the licorice.
I mean, there's other syndromes that kind of present similarly. Is that what you're talking about?
Yeah.
Yeah, you can think about and the differential included like little syndrome when the patient visited nephrology, and that is it can kind of lead to similar. That's like a mutation in some of the channels in the kidney that lead to a similar presentation, but the patient had some urine studies, which I hadn't included, which were not telling for that, but that was certainly something that was considered. And then also, I mean, if you think about, take licorice out of this, if we have excess aldosterone, then that can also kind of cause a similar effect on this pathway.
And besides discontinuation of the licorice, is there any other management considerations for this specific type of situation?
I think either discontinuing licorice or decreasing the amount that the patient is eating, I think is really the only management consideration that I was able to find regarding this. I think there was interestingly, a few years ago, an FDA announcement around Halloween time that was to decrease a warning against consuming excess licorice in the elderly population. And at that announcement, they said to consume less than like 2 ounces per day. So perhaps you could instruct the patient to eat less licorice and see how our labs change.